بس ما عم نقدر نفوت على الشير سكرين. شايفين كل شيء يا جماعة؟
واضح دكتور، واضح
واضح.
واضح
طيب يلا أنا رح بلش يا جماعة. هاي اللكشر اليوم أنا بنظري مهمة كتير، لأن it is the basic of orthopedic basic science. I repeat, it is the basics of orthopedic basic science. يعني بالwritten exam بيجيكم أسئلة كتير إلهم علاقة بهاللكشر. بليز مش بس تسمعوا هاللكشر، روحوا قروا عنا. أنا أخذهم من الأورثوبوليتس، وأخذهم من AO review course، وأخذهم من قسم منهم من نتر. So you can find all what I'm saying in these. وشغله تاني انا قايل له بيعطيكم ريكوردينج على اللكشر، يعني فيكم تستعملوا كل شيء. واتس نوت ايزي، مشان هيك ليه قبل الفحص من اليوم ورايح راجعوا كل يوم لحتى يخرط يفوت على عقلكم وما تنسوها. Before I go into metabolic bone diseases, I would like to go into normal bone metabolism. Normal bone metabolism is the complex sequence of bone turnover. What do we mean by bone turnover? The bone formation and bone destruction. The osteoclast up bone. On the other hand, the osteoblast forms bone. So there is, in normal situations, there is a balance between bone formation and bone destruction. A bit about the physiology of bone metabolism. Bone, as you all know, has structural and metabolic functions. The metabolic functions of bone are largely involved on the homeostasis of calcium and phosphate. We all know that the major part of bone is made up of calcium and phosphate, and it is present in the hydroxyapatite crystal. Release of calcium or absorption of calcium by bone is largely regulated by hormones and less so by steroids. Keep this in mind. The balance and the control of calcium and phosphorus is through the effect and steroids. Never forget this. What are the hormones? These are parathormone, calcitonin, sex hormones, growth hormones, and thyroid hormones. You should all know that parathormones are formed by the chief cells in the parathyroid gland. We have 4 parathyroid glands. They lie behind the thyroid gland. The calcitonin is formed by the parafollicular cells of the thyroid gland. Then you have the sex hormones. So these are all important for the control of calcium, phosphate, osteoblastogenesis, and osteoclastogenesis of bone. Please don't forget this. The steroids are vitamin D and glucocorticosteroids. What about the properties of bone metabolism? The bone mass. The bone mass is the measure of bone tissue present at the end of skeletal maturity. It represents both its volume and size, as well as the density of mineralized tissue. When we say peak bone mass, what do we mean? We ask this question. What do we mean by peak bone mass? It is the upper level of bone formation that occurs in any particular region between 16 and 25 years. It is greater in men and African Americans. So pay attention. Depending on this peak bone mass, will tell you how much you're going to suffer. If you have a high peak bone mass, the chances of you developing osteoporosis is low. If you have a low peak bone mass, vice versa will happen. انتبهوا على البيك bone mass. Bone loss. Bone mass decreases by 0.3 to 0.5% per year after skeletal maturity. But انتبهوا لما قلت لكم it depends on the level of peak bone mass. If it's high, even though you lose, the chances of developing osteoporosis declines. It becomes less. Further decreases by 2 to 3% per year for untreated women during the 6th to 10th years after menopause. The rate of bone loss can be modulated by structural and metabolic factors. Now let's go into each one of them, the calcium, the phosphate. Calcium is located in bone in 99%, in blood and extracellular fluid 0.1%, intracellularly 1%. So you can see that the far majority of calcium is deposited in bone, and mainly in the hydroxyapatite crystal. The function, what does calcium function? It has a wide function. Calcium has a wide range of function, including muscle cell contraction, nerve conduction, and clotting mechanisms. What are the forms of calcium? We spoke about the majority being in hydroxyapatite crystal. Ya Jamia, you should memorize this formula, C810PO46OH2. This is the hydroxyapatite crystal in which calcium is stored. What about the serum, the small amount of calcium that we spoke about? Calcium can be bound to protein in 45%, and free ionized calcium 45%, and in 10% it exists bound to anions, citrate, and bicarbonate. The regulation. Calcium is absorbed from the digestive tract. We all know that the duodenum is the area where calcium is absorbed. It is absorbed by an active process through mRNA connections, and then it's transferred. Resorption from bone does occur through the effect of vitamin D3 and parathormone, and resorption occurs in the kidneys. So if we ask this question, the three sites of resorption of calcium, yani it's brought into the body, is from the intestines, from the bone, and from the kidneys. Don't forget this. What are the dietary requirements? In lactating women, in women who are breastfeeding their child, they need a higher level of calcium, and they need 2,000 milligrams per day. In pregnant women who are not lactating, they need 1,500 milligrams per day. If a patient has a fracture, they need between 1,500 milligrams per day and 2,000, and 1,300 milligrams per day for normal adolescents and young adults. In adults, let's say after the age of 30, they need 750, and in children, 600 milligrams per day. Dysfunction, as we know, or when we say it's an abnormal function, we mean by whenever an individual has hypercalcemia or hypocalcemia. He has a process going on which is not normal. What about the phosphate? We finished with calcium. Remember that calcium is resorbed from 3 places. Remember that calcium is stored in bone, in the hydroxyapatite crystal. In 99%, it can be extracellular, intracellular. In extracellular, they are attached to citrate, bicarbonate. So don't forget these points, please. Phosphate. The location, calcium was 99% within bone. Phosphate, 86% within bone. And in blood and extracellular fluid, 0.08%. While intracellular, they have 14%. Intracellular. Why? Because phosphate takes place with certain functions, certain energetic functions, combinations, and actions within the cell. So that's why phosphate is high within the cell. It is the key component of bone mineral. And it is, as I said, important in enzyme systems and molecular interactions. So don't forget this. Lesh, why do we have phosphate within the cell 14%? Remember, because it's important in enzyme systems and molecular interactions. The forms of phosphate. In bone, we said that the majority of calcium and phosphate are in the hydroxyapatite crystal. In the serum, it exists mostly as an inorganic phosphate, H2PO4. The regulation, plasma phosphate, is mostly unbound and resorbed by the kidney. It may be excreted in the urine. An elevated serum phosphate can lead to an increased release of PTH and bone resorption. آخر statement. بدي فهمكم إياها. When the phosphate rises, we know that there's a CP product of 36. When the phosphate rises, the calcium drops. When the calcium drops, it stimulates the parathyroid glands, the chief cells, to form parathormone so as to absorb more calcium from the intestines and from the bone and resorb any calcium from the convoluted tubules and distal convoluted distal tubules of the kidney. The dietary intake of phosphate should be between 1,000 and 1,500 milligrams per day. Parathormone structure consists of 84 amino acid peptide. Many ask me, what is the atomic weight? What is the molecular weight of parathormone? It is 8,000. The origin, it's synthesized and secreted from chief cells in the 4 parathyroid glands. هول الصغار اللي قد حبة الحمص يلي موجودين ورا الكدني ورا الثايرويد gland. The net effect, it increases serum calcium and it acts to increase phosphate loss through the urine. It decreases it. So don't forget this. The mechanism in bone, parathormone stimulates the osteoblasts to secrete interleukin-1, interleukin-6, and other cytokines. These are all cytokines. They act to stimulate the production of rankle. And rankle acts on the osteoclast. And the osteoclasts act on bone and they resorb bone. So don't forget this. Please analyze this in your mind. You should know this throughout your life because this is the basis of orthopedics. Increases osteoblast production through the macrophage colony stimulating factor and rankle. This is what I was telling you, which increases the number of osteoclasts. And these osteoclasts are so happy. They have pseudopods, they have, and they can act on bone through Hosch's lacunae, which are defects within the bone to resorb bone. They resorb calcium. Paradoxically, osteoclasts do not express receptors for PTH. It is an indirect effect. It is through the production of osteoblasts, through the productions of interleukin-1 and 6, plus other cytokines that will stimulate the osteoblast to form rankle, and the rankle will stimulate the formation of osteoclasts, and they would activate them to destroy or erode bone through Hosch's lacunae. Kidney stimulates enzymatic conversion of 25-hydroxy vitamin D3 converted to 125 dihydroxy vitamin D3 active hormone form. خلينا نقول لكم إياه. We know that in the skin, when we sit in the sunlight forms dehydrocholesterol, and this is taken to the liver, and it is formed as hydroxy vitamin D3. It is hydroxylized by an action of a hydroxylase, after which this is transferred to the kidney in the proximal convoluted tubule. It is converted through the action of a 1-hydroxylase to 125 dihydroxy vitamin D3, and this is the active form. It behaves, it acts just like parathormone. It increases the absorption of calcium in the kidney. It increases the serum calcium. It increases the excretion of phosphate from the kidney. It decreases serum phosphate. So don't forget these points. The intestine, there is no direct action. Indirectly, it increases calcium absorption by activating the 125 dihydroxyvitamin D3. And it is this which stimulates absorption of calcium from the duodenum, from the intestine. This function, parathormone-related protein and its receptor have been implicated in metaphyseal dysplasia. Parathyroid hormone-related protein has related effects to parathormone as it binds to the same receptors on osteoblasts and renal cells to increase serum calcium. So pay attention to this. You have to know, you have to keep in mind that the parathormone-related protein and its receptor is related to metaphyseal dysplasia. Don't forget this. This is a dysfunction. And there are certain lesions which form a parathyroid hormone-related protein, and these compete with the parathormone in function. They have a similar function, and these can do harm more than benefit at times. What about calcitonin? And as we said, that vitamin D consists of 84 amino acids. The calcitonin consists of 32 amino acid peptide hormone, and its molecular weight is 3,000, while the vitamin D is, while parathormone is 8,000. So we have calcitonin and we have parathormone. I apologize. It is the parathormone which has a molecular weight of 8,000. This has a molecular weight of 3,000. So don't forget calcitonin and parathormone. The origin is produced by the clear cells in the parafollicles of the thyroid gland. We call these the C cells. The net effect is a limited role in calcium homeostasis. It inhibits the number and activity of osteoclasts. It produces a guide against osteoclasts coming to bone and destroying bone. If you have an elevated calcium, calcitonin will be released to deposit the calcium in bone. Not like parathormone. If parathormone comes, it wants to remove calcium from bone. They have a counter action. The function in bone, it inhibits osteoclastic bone resorption by decreasing the number and activity of osteoclasts. As I mentioned, the osteoclasts have a receptor for calcitonin, but they don't have a receptor for parathormone. Remember this, don't forget it. There is no receptor on the osteoclast for parathormone, but there's a receptor for calcitonin. Whenever you have an increased serum calcium, you have in response by the cells, the parafollicular cells in the thyroid, to release calcitonin and inhibit the osteoclast from resorbing calcium from bone. A bit about the dysfunction. It's secreted by the medullary thyroid tumors. That's a problem. And multiple endocrine neoplasia type 2 tumors. Recombinant calcitonin is used to treat Paget's disease, as you know, osteoporosis, and hypercalcemia in malignancy. So it has a useful function and it has a bad function. Why? The same product is secreted by the medullary thyroid tumors in excess and in multiple endocrine neoplasia type 2 tumors. Coming to vitamin D. Vitamin D, you all know that it's a fat-soluble corticosteroid, meaning that it's a steroid with a broken ring. The origin, it's produced by skin when exposed to sunlight. Don't forget. Ultraviolet light, as I mentioned, it forms vitamin D, which is taken to the liver, and from the liver, 25 hydroxylase hydroxylates into 25 hydroxyl vitamin D3, and then to the kidneys. In the diet, vitamin D is known as ergosterol, and it's a lipid-soluble vitamin D3. The active metabolite is 1,25-dihydroxy vitamin D3 formed by 2 hydroxylations, as I mentioned, in the liver and in the kidney, respectively. So keep this in mind, because let's forget this, because in exams we ask this. Okay? The net effect, it maintains a normal serum calcium levels by activating the osteoclast for bone resorption and increasing intestinal absorption of calcium. It increases serum calcium. It promotes the mineralization of osteoid matrix. It promotes the mineralization of osteoid matrix. What does that indicate? In children, if we don't have vitamin D, then there won't be a normal mineralization. And what sets in? Rickets. In adults, osteomalacia. So don't forget, vitamin D is an important structure in the body, an important product. A bit more about the function. In the liver, activated vitamin D3 is you're asked, what activates the active form of vitamin D3, which is 1,25-dihydroxy vitamin D3, and you should say it's PTH, and decreased levels of serum calcium and phosphorus. These have a retrograde stimulus on the parathyroid glands to form parathormone so as to form more vitamin D3. Now, 1,25-dihydroxy vitamin D3 is the active form, but when it's inactivated, it is in the form of 24,25-dihydroxy vitamin D3. Inactivity occurs with decreased levels of PTH, increased levels of serum calcium and phosphorus, and vitamin D parallels that of PTH, reabsorption of calcium in the kidneys. Now, am I clear so far? Khalid, is everybody understanding what I'm saying? ما حدا عم يسمع؟ خالد.
دكتور جون، أسمعك.
Am I clear? واضح؟
فيري كلير، واضح جدا والكل يسمعوك والصالتين مليانات. الحمد لله.
اوكي، انا بيهمني انه اذا منهم فاهمين شيء يسالوني، لان this
لا
is the
لا
basics of orthopedics يا جماعه.
البيسك تكس هذا
هي كل شيء بالاورثوبيدكس،
كل حاجه بالاورثوبيديك وغير بالاورثوبيديك. هم بيسمعوك يا
اوكي
دكتور جون وفاهمين يعني.
اوكي سير.
شكرا لك.
Bone 125 dihydroxy vitamin D3 stimulates terminal differentiation of osteoclasts. When osteoclasts mature, they do not respond to 125 dihydroxy vitamin D3 and respond mostly to cytokines released by osteoblasts. There are no receptors on the osteoclast for vitamin D. So you have to pay attention. It is an indirect effect which acts on the osteoblast to produce a rankle, and the rankle acts on the cytoclast, on the osteoclast. So osteoblast, VS rankle, VS as resorption of bone. 125 dihydroxy vitamin D3 promotes the mineralization of osteoid matrix produced by the osteoblasts. Vitamin D deficiency causes osteomalacia and rickets, as I mentioned. Patients who have epilepsy and they're on phenytoin, dilantin, they have a vitamin D deficiency, and they can, if they're young, they can have rickets. So don't forget this. Estrogens, growth hormone function, it increases serum calcium by increased absorption in the intestines. It decreasing urinary excretion, and the function is interdependent with insulin, somatomedins, and growth factors. هولي بدكم تحفظون. Growth hormone is known to promote gigantism and oversecretion or increased response to growth hormone, affecting the proliferative zone of the growth plate. This gives us the explanation. When you give growth hormone to rats or to immature rats, you see that there's an increase in length of bone. Thyroid hormone. Thyroid hormone regulates skeletal growth at the physis by stimulating chondrocyte growth, type 10 collagen synthesis, alkaline phosphatase activity. Thyroid hormones increase bone resorption and can lead to osteoporosis. We know it. It's a high output osteoporotic condition. Large doses of therapeutic thyroxine can mimic this process, and they cause osteoporosis. Steroid function, increase bone loss by decreasing calcium absorption in the intestine through a decrease in binding proteins. We know that in the duodenum, it has to bind with proteins to be able to be passing through an active phase, an active process. It decreases bone formation, cancellous more so than cortical bone, by decreasing collagen synthesis and inhibiting osteoblast activity. Ya Jama'a, holy, you have to memorize. You have to understand, what does steroids do? You have to understand these points. How does growth hormone? What is the effect of insulin? What is the effect of diabetes? Points. Now we come to the section on metabolic bone disease. We are going into the abnormal process. Metabolic bone diseases are disorders of the skeleton resulting from abnormalities in chemical milieu of the body. With rare exceptions, these diseases cause a generalized decrease in bone mass and tendency to fracture. The diagnosis and treatment of specific metabolic bone diseases is usually the job of the endocrinologist. However, because the initial presentation of these diseases are often a fracture due to the weakness of bone, we are the first people to deal with these cases, especially following little or no trauma. Orthopedic surgeons are usually the first physicians to see the affected patients. Orthopedic surgeons must be able to recognize the presence of metabolic bone disease, alerted by the clue of bones that fracture easily. Orthopedists who recognize these diseases get better results from their treatment and are less likely to make the metabolic bone disease worse. Now, from experience, I'll tell you there is quite a large number of orthopedic surgeons who don't know what metabolic bone disease is. The basics of education in orthopedics is to know the basic knowledge in orthopedics. If you don't know this, you might miss many conditions. I'll give you an example. At one of the universities that I work at, they had a latent lesion of the proximal end of the fibula. In the proximal end, they immediately said it's a giant cell tumor. So they removed the head of the fibula. The lesion recurred. Why? Because this patient had metabolic bone disease. It was an excess amount of parathormone, which was acting on the bone, forming a brown. In this lesion, they had hemosiderin, they had macrophages, and everything. When it recurred, they took another biopsy. They said, wow, it looks like it's a giant cell osteosarcoma, and that's why it recurred. Nobody failed to say, did this patient have any studies, especially for the parathyroid gland? If they had, the only treatment was to control the parathyroid adenoma and remove the adenoma, and the patient would have been cured without disturbing the area of bone in which the lesion was present. So you have to pay attention. Please, surgical pathologists like orthopedists depend on the endocrinologist to diagnose specific metabolic bone diseases. Morphologic features of these diseases are best studied by undecalcified bone. You should not decalcify the bone and send it to pathology or for them to evaluate. It should not be. It should remain calcified so as to tell what type of metabolic bone disease. For you to do histomorphometry, and this modality is usually the province of bone biologists or endocrinologists. Pathologists must also recognize the presence of metabolic bone disease, especially when studying tissue specimens removed by orthopedic surgeons. By doing this, they may then initiate a dialogue with the endocrinologist and bone specimens and with the orthopedist. I have to stress this. And they might find their way to the hard tissue laboratory and arrive at a diagnosis. Because metabolic bone diseases usually result in decreased bone mass, two terms must be defined at this point. Decreased bone mass, when described radiographically or histologically, is known as osteopenia. Symptomatic osteopenia with bone pain or fractures is the clinical syndrome that we all speak about, osteoporosis. Osteopenia is a decrease in bone mass greater than 2.0 standard deviations below normal, as measured by densitometry techniques. Osteoporosis is a decrease greater than 2.5 standard deviations below normal. يا جماعة أوقات من بجيكم من DEXA scan or من densitometry. You have to know how to read. You should look at the T-score. Look at how much it is. Then you can say whether there is osteopenia or osteoporosis. Metabolic bone diseases may be grouped into three major categories. The first category includes diseases caused by specific endocrine abnormalities, particularly those which disturb calcium homeostasis. Because parathyroid hormone and vitamin D are critical for calcium homeostasis, excess or deficiency of these compounds has a profound effect on the skeleton. The effect on the skeleton in these cases is specific, and the cause can be diagnosed histologically or biochemically. You have to know what studies you should ask. You have to look at the bone, study the x-rays. The second category of metabolic bone diseases includes osteopenic syndromes without specific endocrine abnormalities, particularly age-related osteoporosis. Although humeral abnormalities are etiologic factors in these syndromes, laboratory studies are usually normal, and the osteopenia is due primarily to a gradual decrease in the organic matrix of bone. The third category of metabolic bone disease represents the osteopenic syndromes due to disuse. Bone health is dependent on stress and strain of physical activity. Absence of stress and somehow results in non-physiologic bone remodeling and gradual bone loss. As when one hasn't walked for a certain time, then he overstresses, you can get a stress fracture. Specific endocrine disorders, primary hyperparathyroidism. Right. I would like to rest 1 minute, 2 minutes, and take a rest period for 1 or 2 minutes. شو رأيكم يا جماعة؟
دكتور جون
1 minute rest، شو رأيك؟
اوكي هيك
لحتى احكي.
ريح ما عليك احنا
1 minute 2 minutes. Primary hyperparathyroidism.
دكتور شباب
يلا رجعت يلا. primary hyperparathyroidism. خلي ساعة عم بحكي لكم على الباراثايرويد glands. This diagram is taken from Netter, and I believe that it's a beautiful diagram. على التوب تبع الدايجرام it shows you the thyroid gland with various conditions in which you can have an excess parathormone. On the left-hand side, you see a localized adenoma in one of the 4 parathyroid glands. If you remove this, the patient is cured of his problem. At the middle, you see that there's hyperplasia of all glands. If you remove 3.5 of the glands, you can cure the patient. Carcinoma is very rare. All of them produce parathormone. All of them would stimulate the production of vitamin 125, vitamin D3, and all will end up acting on the proximal convoluted tubules, on the reabsorption of calcium and loss of potassium. So you have to know this. And in other important, they act on the intestines. So be careful. Study this diagram. Study it carefully, and you would really understand the problem of endocrine metabolic bone disease. So what do these patients have? Primary hyperthyroidism. They can have also various changes. They can have also changes on parathormone. So you have to pay attention to these. Some form calcification, some produce destruction, some form cataract ulcers, some form pancreatitis, some form biconcave vertebrae, or what we call the codfish vertebrae. So you have to pay attention to this. All these act on the calcium and phosphorus metabolism. Now let's come to renal osteodystrophy, which is secondary to hyperparathyroidism. The brown tumor of the proximal phalanx is shown over here. And osteitis fibrosa cystica of the distal femur. So you can see what parathormone can cause. You can see it destroys bone by resorbing calcium. You can see that it forms brown tumors. You can see that there's hemosiderin collections. You can see that it can mimic any tumor of bone. So you have to know about this. The presentation of hyperparathyroidism has changed in recent times. Formerly, primary hyperparathyroidism was a rare disease and florid skeletal complications. Nowadays, however, primary hyperparathyroidism is common. It is very common. As many as 1 in 500 to 1 in 1,000 persons are affected in the United States. Imagine, so you have to do a full investigation on your patients. After diabetes and hyperthyroidism, hyperparathyroidism is the most common endocrine disorder. Also nowadays, the skeleton is rarely involved. Less than 5% of patients have clinical bone disease. Why? Because we are detecting them early, we are able to treat them. This change in the incidence, a 4 to 5-fold increase, and presentation of hyperparathyroidism began in the early 1970s with the use of the autoanalyzer. This laboratory machine routinely screens serum calcium levels in patients, evaluate for other reasons. So keep this in mind. As a result, hyperparathyroidism can be diagnosed very early in its long natural history, providing you ask for the blood tests, providing you investigate for it, providing you keep it in mind that this exists. At this point in the disease, patients are asymptomatic and the skeleton is not yet affected. Probably many of these patients would have gone undiagnosed in their lifetime if lab studies weren't done. So you have to pay attention. Please pay attention. Primary hyperparathyroidism is caused by an oversecretion of parathyroid hormone by the parathyroid glands. The effects of increased parathyroid hormone secretion on bones, kidneys, and indirectly on the intestines causes hypercalcemia, as I've repeatedly stated in this lecture until now. Don't forget this. In 80% of cases, a parathyroid adenoma, one gland, causes this disease. The other 3 glands are normal. In most of the remaining cases, the hypersecretion of parathyroid hormone results from hyperplasia of all 4 glands that I've told you, and a condition which occurs in multiple endocrinopathy syndromes. Parathyroid carcinoma is the least, thank God, another cause of primary hyperparathyroidism, and this only accounts for 0.5%. The far majority are adenomas. Then comes hyperplasia, and least comes the adenoma, which is only 0.5, and which least comes carcinoma, and not fully understood. Ordinarily, rising serum calcium levels turn off parathyroid hormone secretion, but this function is modulated in cells of a parathyroid adenoma, and the result is a higher set point. يعني ما بتعود تتجاوب. لما الكالسيوم levels become normal in the blood, it continues to secrete in an adenoma, and even in hyperplasia, and even in carcinoma. Thus, an adenoma is the origin of the adenoma cells suggest genetic defect in the control of parathyroid hormone secretion. And in some patients, a gene arrangement or rearrangement at the site of PRAD1 oncogene has been demonstrated. In 1891, von affection of the skeleton, which he called osteitis fibrosa cystica generalizata. For several decades, this term was used to describe a variety of bone disorders. This included Paget's disease, osteomalacia, and other lesions characterized by skeletal deformity and cysts. The origin of osteitis fibrosa began to be elucidated at the turn of the century. In 1901, Ashkenazi had shown that the parathyroid glands influence the calcium metabolism of the skeleton. Then in 1925, Collip demonstrated that parathyroid extract prevented parathyroid tetany and regulates serum calcium. Why? Why does it prevent tetany? Because we know that when the calcium level drops and the patient has hypocalcemia, they will go into tetanus. They will have tetanus convulsions. When you give parathormone, it extracts calcium, the level of the blood, calcium turns to normal, and it prevents convulsions. A year later, Mendel performed the first parathyroidectomy for an adenoma and successfully ameliorated the skeletal changes of osteitis fibrosa. The relationship of the parathyroid gland to skeletal disease was confirmed in the year 1931. In that year, Jaffe, Blair, and Bodansky, working at the Hospital for Joint Diseases in New York, experimentally produced osteitis fibrosa in rabbits by injecting parathyroid hormone. What are the clinical features of primary hyperparathyroidism? It occurs in any age. ما حدا يقول لي brown tumor ما بتيجي بهالعمر وبتيجي بهالعمر. It's not true. It occurs at any age. It is most common in the 6th decade of life. And we know it's more common in women, 3-1. If you have an unstable woman who's losing weight and she has aches and pains in all her joints, you have to do a workup on parathyroid gland. Therefore, the majority of patients with primary hyperparathyroidism are postmenopausal women. Asymptomatic hypercalcemia is the most common clinical presentation. However, calcium values rarely exceed 1 milligram per deciliter over the upper limits of normal. These patients are usually discovered with routine screening studies and have no complaints referable to the parathyroid hormone target organs. The diagnosis is confirmed by an elevated serum parathyroid hormone, a finding present over 90% of patients. In addition, serum phosphorus may be low and alkaline phosphatase elevated, although these changes are inconstant. Although most patients with primary hyperparathyroidism are asymptomatic, some have vague symptoms, some have easy fatigability, some have muscle weakness, some have a sense of being ill at ease, and in more advanced cases, target organ complications occur. So again, be aware of this. Nephrolithiasis, affecting 20% of patients, is the most common complication. As with skeletal complications, nephrolithiasis was formerly more common. 33% of cases in the 1960s had nephrolithiasis. In addition to nephrolithiasis, nephrocalcinosis also occurs. The gastrointestinal tract may also be affected with hyperparathyroidism. As I mentioned, you can have peptic ulcers and pancreatitis. However, these complications are also now rare because of early diagnosis, and thanks to you, the future generation of orthopedic surgeons who are going to be very aware of this condition. What are the skeletal manifestations of hyperparathyroidism? What are the radiographic features? Plain radiographic changes are rare in primary hyperparathyroidism. When present, the most characteristic feature is subperiosteal bone resorption. This change first occurs in the tufts of the distal phalanxes or along the radial border of the middle phalanges. This is the first change. بدي اياكم تطلعوا بهالصورة. طلعوا بالمطرح الارrows. You see the distal phalanx is resorbed. This is what is meant by the distal tufts, TUFTS, are resorbed. بعدين, if you look at the radial aspect of this phalanx, you see there is resorption, subperiosteal resorption of the cortex in the middle phalanges. You see it's most marked here. I'll show it on another larger view. You can see it over here, okay? Resorb, usually on the radial aspect, but it can be on both aspects. Look at the clavicles. You see that there's osteolysis of the outer end of the clavicle. Don't confuse this with osteolysis that occurs in bodybuilders. Many times I get patients who are bodybuilders, osteolysis of the outer end of the clavicle, and the only treatment is to stop whatever sports he's doing. Now, in hyperparathyroidism, we get it, so you have to keep it in mind. Look at the skull. They have salt and the pepper appearance of the skull. You see this on the X-ray. And then you get brown tumors. These are the result of extensive bone resorption caused by hyperparathyroidism. Okay? They may be multifocal, shown in the next slide. They are called brown tumors because the gross tissue is pigmented with hemosiderin, secondary to extravasated erythrocytes. What happens? The erythrocytes die, the macrophages take them, and they have excessive hemoglobin and hemosiderin within the macrophages. They appear brown. However, they are rarely seen in primary hyperparathyroidism. Nowadays, brown tumors occur most or almost exclusively in advanced secondary hyperparathyroidism. This is a plain radiograph of the pelvis in advanced hyperparathyroidism. There are multiple lytic lesions throughout the skeleton. Although plain radiographic changes are rare in primary hyperparathyroidism, densitometry studies are much more sensitive. Approximately 50% of patients will show demineralization with X-ray absorptiometry studies. This modality demonstrates the loss of bone, and the loss of bone is mainly cortical, as I showed you in the subperiosteal erosion. Of sensitivity, densitometry is an important tool in evaluating therapy for all cases of primary hyperparathyroidism. Pathologic changes. Pathologic changes. Because primary hyperparathyroidism is usually diagnosed early, tissue samples removed from affected patients rarely show significant pathologic changes with routine microscopic techniques. A few resorption cavities may be noticed in the trabecular bone. The bone changes are best evaluated by histomorphometry techniques. This modality demonstrates an increase in both bone resorption and bone formation, a so-called high turnover state. There is an increased number of resorption surfaces and an increase in osteoid surfaces. Mineralizing surfaces, as indicated by extent of tetracycline labels, are also increased. The high turnover of primary hyperparathyroidism is generally balanced. Bone formation equals bone resorption. Therefore, cancellous bone volume is usually normal. It is maintained. A distinctive change, however, is present in the majority of patients is a reduced amount of cortical bone. That's what I was saying. The effect of paratormon is mainly on the cortex. Reduced cortical bone is reflected histomorphometrically in both a decreased cortical thickness and an increased cortical porosity. In the advanced cases of parathyroid hormone, excess usually seen only in secondary hyperparathyroidism, extensive osseous changes occur. The most characteristic tunneling, resorption. This is what we mean by tunneling. This is a low power photomicrograph of cancellous bone. In hyperparathyroidism, there is tunneling resorption of the trabeculae. This unusual pattern of resorption occurs because osteoclasts cannot penetrate the seams of unmineralized osteoid, which covers the trabecular surface. That's why they have tunneling. ما في عدم تاكلوا الاوستيوكلاست. في osteoid tissue which osteoclasts have no effect on it. Therefore, they must tunnel into the center of the trabeculae where they have access to the mineralized surface. In addition to tunneling resorption, other changes of advanced hyperparathyroidism include extensive woven bone deposition and paratrabecular fibrosis. What we mean by woven bone is irregular bone formation. We don't see them in a regular fashion. The trabeculae are irregular, etc. And this is the primary bone formation. Treatment of primary hyperparathyroidism. Primary hyperparathyroidism can be cured by surgical removal of the gland containing the adenoma. In the cases caused by parathyroid hyperplasia, 3 1/2 gland parathyroidectomy usually results in restoration of normal calcium balance, and after surgery, bone mass improves substantially in 2 to 4 years. About 50% of patients with primary hyperparathyroidism can be managed medically, and these patients are usually asymptomatic and have no evidence of bone or renal disease. Also, mildly symptomatic older patients who are poor surgical risks can be treated conservatively. Conservative treatment consists of adequate hydration and low calcium. Regimens may also include drugs which inhibit osteoclasts, such as estrogen or biphosphonate. Hypoparathyroidism. Are there any questions? Any questions? يا جماعة في أسئلة؟
دكتور جون معك. لا تمام الحمد لله الامور واضحه يعني
Khalid,
لو
are you
في
sure they are understanding? They
يا
have to know what hyperparathyroidism is. They have to
يا
know the signs and symptoms, what lab studies, how should they do histochemistry on these patients, why should they use كلهم
Yeah,
هول. You have to know them.
they are understanding and they should most of them read before your lecture. Everything is clear. Thank you.
Okay, hypoparathyroidism. Now,
Okay.
hypoparathyroidism results in hypocalcemia, hyperphosphatemia, and secondary decreased 125 vitamin D3 levels. Primary hypoparathyroidism is uncommon. Isolated hypoparathyroidism results from inherited conditions that affect either parathormone or ionizing calcium sensing receptor. Yani the calcium is not responding to parathormone. We have more parathormone, but calcium senses do not respond. Primary hypoparathyroidism may also result from more complex endocrine disorders. The clinical manifestations of chronic hypoparathyroidism include non-specific mental symptoms such as lethargy, irritability, and depression, as well as cataracts, alopecia. They lose hair, alopecia. They have poor tooth formation. Bony changes are minimal. I repeat, non-specific mental symptoms such as lethargy, irritability, depression, as well as cataracts, alopecia, and poor tooth formation. The bony changes are minimal. Pseudohypoparathyroidism is caused by impaired response and organ resistant to PTH, as I mentioned. PTH cannot act on the proximal renal tubules to form vitamin D3, 125. It cannot. They're not responding. بدق الباب ما في جواب. A variety of disorders cause pseudo-hypoparathyroidism, including decreased levels of GSA and the G protein responsible for coupling the receptor in the cyclic adenosine monophosphate signal transduction pathway, pseudo-hypoparathyroidism type 1 alpha. They have a reduced expression of PTH receptor type 1b, impaired activity of adenyl cyclase, which synthesizes CAMP type 1c, and other uncharacterized effects in parathormone and organ response. So you can see that there is a variety of causes, but the overall cause is that we have an insensitive zone in the proximal convoluted tubules that don't respond to parathormone, and therefore they develop pseudo-hypoparathyroidism. Individuals with pseudo-hypoparathyroidism type 1A and 1C also have Albright's hereditary osteodystrophy. This is a patient who has pseudo-hypoparathyroidism. You see that on the whole they're short, they have a pot belly, and they are a bit obese. But then if you look at the hands and feet, you see that the fourth metacarpal and fourth metatarsal are short. The knuckles are not prominent at the fourth level. And this is typical of the finding. So they are short, they are obese, they have a round faces, they are mentally retarded. A lot of these patients are in institutions. Disorders of mineralization, namely rickets and osteomalacia. We spoke about the normal calcium metabolism. I won't go through it. We spoke about the regulation of calcium. We spoke about the tumors that regulate calcium metabolism. So you have to pay attention and you need to study these. These are taken from NETA. Both serum calcium and serum phosphorus must be at sufficient levels to mineralize growing cartilage and bone. If either is low, mineralization is inhibited and patients develop rickets or osteomalacia. There are several conditions in which these can be low, and they include vitamin D deficiency, inadequate sun exposure, low dietary intake, vitamin D malabsorption, gastrointestinal surgery, gastric bypass, Bilirubin 2 gastrectomy, and small intestine disease. SPRU, celiac disease, liver disease, vitamin D metabolism abnormalities, renal failure, and dilantin therapy, as I mentioned. Oncogenic osteomalacia. These produce a parathyroid-like hormone, and these can lead to osteomalacia. Congenital condition, vitamin D-dependent rickets type 1, and vitamin D-dependent rickets type 2, and X-linked hypophosphatemic rickets. So these you have to know. Rickets is due to ineffective mineralization of the growth plate and causes deformity and growth retardation. By contrast, osteomalacia, meaning soft bones, is due to poor mineralization of osteoid. As a result, unmineralized osteoid accumulates on trabecular and cortical surfaces. Because growing bones undergo extensive modeling and oppositional bone formation, children with mineralization defects develop both rickets and osteomalacia. Adults can only develop osteomalacia. Since bone mineral is composed of both calcium and phosphorus, it is convenient to classify rickets and osteomalacia according to the particular deficiency, calcium or phosphate. Calcium deficient means calcipenic conditions, and they are more common and include low calcium intake and vitamin D deficiency, either primary or secondary. Almost always, these calcipenic disorders are complicated by secondary hyperparathyroidism, and the clinical, radiographic, and pathologic features are similar. Phosphorus deficient conditions also cause rickets and osteomalacia. However, because serum calcium is usually normal in these conditions, secondary hyperparathyroidism does not occur. Phosphate deficient states include renal disorders with phosphorus leakage and oncogenic osteomalacia. Loss of phosphorus also occurs in the genetic syndromes resulting in hypophosphatemic rickets. Some patients with these syndromes not only have rickets, they also have radiodense bones, a feature possibly related to an additional defect in bone-forming cells. Although uncommon in recent years, rickets was formerly a major cause of childhood illness. بإنجلاند كان في عندهم so many rickety patients. Why? Because they don't have sunlight and they were malnourished. It reached its peaks during the Industrial Revolution when many children lived in slums of the cities. However, the disease was well documented in medical treatises before the Industrial Revolution. Although the origin of the term rickets is obscure, Gleason suggested that the term derives from the Greek rachitis, meaning spine, because it affected children and often resulted in kyphosis. So in Greek, it's known as rachitis, kyphosis. It was not until 1890, however, that the etiologic understanding of rickets began to unfold. In that year, Theobald Palm gathered worldwide data and concluded that the lack of sunlight was a causal factor. Rickets was widespread. In 1899, Church reported that in Vienna, 97% of infants between 9 and 15 months had clinical evidence of rickets. However, by 1917, Hess et al. Described the prevention of rickets by using cod liver oil or by ultraviolet irradiation. Nutritional rickets is almost always due to an inadequate supply of vitamin D, although a low calcium intake can also cause this disease. Inadequate sun exposure was formerly the main cause of low vitamin D levels. Food supplementation with vitamin D2 has greatly reduced the incidence of rickets in developed countries. By contrast, in certain cultural groups, both in developed and developing countries, consumption of to sunlight still causes vitamin D deficiency. Nearly 30% of children in an Ethiopian clinic showed evidence of rickets. They wrapped their children and they don't leave them exposed because they are afraid from the evil eye. They swaddle them. Also, the Middle East, female children, when totally covered outdoors, is likely to result in rickets. 40% of females in Pakistan had skeletal evidence of this disease. Breast milk is low in vitamin D. Breastfed infants among these cultural groups are especially at risk. A bit about the pathogenesis and pathology of calcipenic rickets. Look at these. You have the child on the left-hand side and the adult on the right-hand side. If you look of the height of these children, it is impaired. They have craniotavies in the infants. You see that the skull is soft. You see that the fontanelles do not close. They have frontal bossing. They have dental defects. They have a chronic cough. They have a pigeon chest, a tunnel chest. They have round prominences at the costochondral junction, which is called the rachitic rosary. They have defects or depressions in the rib, secondary to the negative pressure created by breathing. And these are called Harrison's groove. They have flaring of the ribs. They have enlargement of the wrists and the joints, the knee, etc. They have coxavara, meaning that the hips are in varus. So don't forget, because they have a slipped epiphysis. And they are bowing of the legs. All these are present. So you have to think of it. The x-rays on the right-hand side show you of how they have clubbing of the joints. They have flaring of the metaphyseal ends of the tibia and femur. The growth plates are thickened and irregular due to lack of calcification. They have a lot of endosteal tissue, but they don't have ossification, calcification. So don't pay it, and don't forget this. When you have calcification, it can be fuzzy and indistinct. The bone cortices are very thin. They have coxavara and slipped capital femoral epiphysis. They have multiple areas of lucency and density of pelvic bones. So please don't forget these, okay? And it goes to tell you of how you have endosteum, you have formation of endosteal tissue, but no calcification. So this is it. The cartilage is not resolved. We know that we have the resting zone. We know that we have the proliferating zone. We have the hypertrophic zone, and then the zone of provisional calcification by invasion. But this does not exist. And so you see that a large amount of the cartilage is present, but it's not ossified. So you have to keep this in mind. Please look at it, study it well. You look at the physis, see of how wide it is. Okay, so don't forget these. Calcipenic rickets is caused by inadequate serum levels of ionizable calcium. As a result, the growing epiphyseal plate fails to mineralize properly. Usually, calcium is low because of the poor intestinal absorption due to low levels of vitamin D. Although compensatory rise in parathyroid hormone secretion raises the serum calcium, increased parathyroid hormone causes phosphaturia and a high turnover bone resorption. This sequence explains the usual biochemical features of rickets. Normal or low serum calcium, low serum phosphorus, low 25-hydroxy vitamin D, elevated PTH levels, and an elevated serum alkaline phosphatase. Pathologic changes are apparent in the growth plates and in the bones. Inadequate mineralization causes marked distortion of the growth plate. There is lack of calcification and destruction of the cartilage. The zone of hypertrophy of the physis is not resolved and invaded by the provisional zone of calcification. The zone of provisional calcification is poorly defined due to scanty mineral deposition. Because a well-mineralized bone of provisional calcification normally provides a feedback inhibition to the zone of proliferation. Poor mineralization leads to unregulated chondrocyte proliferation As a result, the gross plate thickens sometimes 5 to 15 times the normal thickness. There is gross distortion in the orderly zone of chondrocyte columnation and hypertrophy. Therefore, the epiphyseal plate the epiphyseal plate is soft and mechanical forces squash it into the metaphysis. If you look at this wrist x-ray, you see that there is cupping of the physis. What has happened? The physis has herniated through the metaphysis due to the inefficient calcification of the zone of hypertrophy and the production of the provisional zone of calcification. The rachitic bones show abnormalities consistent with osteomalacia. Wide osteoid seams are present around thin spicules of irregular trabeculae. The cortices are thin and show increased resorption as a result of secondary hyperparathyroidism. What are the clinical and radiological features of rickets? Just looking at this diagram, you can see. Just looking at this patient, look at the pot belly. Look at the various deformities of the femurs, of the tibia. So you can visualize these. Nowadays, the clinical features of florid nutritional rickets are rarely seen in developed countries. However, in rare cases, the changes are striking. The rachitic child is apathetic and irritable. A generalized weak musculature is especially prominent in the abdomen and results in a characteristic pot belly appearance, as I'm showing you over here. I want you to see, look at the pot belly. It's due to muscle weakness. Look at the pigeon chest or the pectus incavatum. Look at it. Look, you can see Harrison's groove on the lateral side over here. I wish I can show it to you. Right over here. This is the pectus incavatum. You can see the pot belly of this patient. Look at the frontal bossing. Okay, and you can see that these patients are looking at the spine, they have a kyphosis. Okay, so keep this in mind. This shows you the rickety rosary, and it shows you the Harrison's groove. You see a groove in the rib. This shows you the pectus or the rickety rosary and the pigeon chest deformity. Children are late in standing and walking. Also severely affected in rickets. The long bones are shortened and the lower extremities are bowed. The hypertrophic cartilage of the epiphyseal plates causes swelling of the wrist, knees, and ankles. The most characteristic radiographic feature of rickets is a widened epiphyseal plate. Also, there is usually a cup-shaped deformity of the metaphysis. We call it metaphyseal flaring due to squashing of the epiphysis into the metaphysis. Plain radiograph of the knee in a child with rickets. There is widening of the epiphyseal plate. طلعوا على الفايسس بتشعوا على wide. You can see epiphysis. So you have to think of, you can pick this up early. And these are present in children who are not receiving sufficient amount of vitamin D, or in the children who have certain congenital defects in the genes, and they have an inheritance where there is no vitamin D formed due to an insensitive area, the proximal convoluted tubules, or the rickets. These changes in the epiphyseal plate present in all forms of rickets. These are pathognomonic. The weight-bearing bones are often bowed, and there is generalized osteopenia, which is particularly prominent in the metaphysis. Many bones show transverse radiodense lines known as looser lines. These lines present in 20% of patients with all forms of rickets. It represents stress fractures and are on the concave side. Pay attention. The stress fractures are on the concave side, while in Paget's disease, the stress fractures are on the convex side. This is a question we ask to confuse you. These lines present in 20% of the patients with all forms of rickets. It represents stress fractures and are most prominent on the concave side in rickets and osteomalacia. Osteomalacia, it's known as Umbozonen, a German name given to it. Looser lines or Umbozonen or stress fractures also occur in the scapulae, the ribs, the clavicles, and the pubic rami. This shows you the pseudofracture of osteomalacia, shows you of the tibia, and it shows you of how the stress fracture occurs on the concave side, and it's called looser zone or umbozonen. And it shows you the widening of the physis, irregularity of the physis due to the irregular deposition of calcium. And it shows you the pot belly and bowing of the legs. Hereditary forms of rickets. As I was mentioning, two forms of hereditable rickets exist. One is the phosphate wasting, which I told you about. Phosphate is necessary for bone mineralization, and phosphaturia in these disorders results in inability to mineralize bone. Drink. Patients are similar clinically to nutritional rickets, but they do not respond to vitamin D therapy. These syndromes are previously known as vitamin D-resistant rickets. The most common of these syndromes is X-linked hypophosphatemic rickets. This is a plain radiograph of the legs and an X-linked hypophosphatemic rickets. There is extensive rachitic changes throughout the bones. You see that the cortex is thin, there is widening of the physis, there is deformity, and even on there are even looser zones. The syndrome results from a mutation of the fixed gene located on the X chromosome. As a result, the fixed gene product fails to inactivate fibroblast growth factor 23. Elevated levels of fibroblast growth factor 23 act on the kidney to block phosphate reabsorption. In addition to hypophosphatemia, there are elevated vitamin D and parathormone levels. The disease varies in severity depending on what parent contributed the X chromosome with the mutation. In general, males are affected more severely than females. The other hereditary form of rickets is autosomal dominant hypophosphatemic rickets. This disorder is caused by an activating mutation that causes the primary elevation of FGF23. The FGF23 gene is on chromosome 12, as I previously mentioned. Another heritable form of phosphaturic rickets is associated with hyperostosis, and the mechanism of this disorder is not clear, but probably is caused by mutation in the gene encoding FGF23. Osteomalacia in adults. Vitamin D deficiency in adults causes osteomalacia. In this disease, new bone deposited during normal remodeling cycles fails to mineralize. As a result, osteoid accumulates at the expense of bone, and the skeleton softens. The rarity of nutritional childhood rickets in developed countries may lead to the conclusion that osteomalacia in adults is also rare. Unfortunately, however, it is common. Over 1 billion people worldwide have vitamin D deficiency. There are several reasons for this. Why? First, more people live into old age, and old people often get inadequate sun exposure and they eat poorly. Second, vitamin D metabolism is abnormal in the elderly. Third, gastrointestinal surgery, common in developed countries, may result in poor vitamin D absorption. And finally, some drugs cause osteomalacia. Memorize these. Remember that old age, they have poor vitamin D and they have inadequate sunlight. Remember that the vitamin D metabolism in the elderly people is not normal. Remember that many people do surgeries on the gastrointestinal tract to lose weight, and this has had a poor effect on the vitamin D. Remember that many people have epilepsy, and they take hydantoin, and this causes osteomalacia. Because older adults are the most common affected, osteomalacia is usually engrafted on involutional or postmenopausal bone loss. Bones become even weaker. Therefore, in caring for any patient with osteoporosis, the clinician must always ask, could this patient also have osteomalacia? Answering this question is crucial because osteomalacia responds to vitamin D therapy, and treatment may reduce the incidence of fractures. The epidemiology. In developed countries, osteomalacia is a disease of the elderly. 3 causal factors contribute to this age predilection. First, because the aging skin has low levels of vitamin D precursors. The elderly require at least 3 times the amount of sun exposure to synthesize enough vitamin D. This is difficult to achieve because older people are often immobile and spend less time outdoors. A second factor contributing to osteomalacia in the elderly is a poor diet. Although vitamin D is added to dairy and grain products, the elderly may eat few of these fortified foods. This problem is exaggerated where there is little choice of meals, such as with institutionalized patients or the homebound elderly. The third contributing factor is elderly patients. They have impaired hepatic synthesis of 25-hydroxyl vitamin D and impaired renal synthesis of 125-hydroxy vitamin D3. These 3 factors conspire to make osteomalacia a common disease of old people. Almost 1/3 of institutionalized patients and 54% of the homebound elderly are vitamin D deficient. 1/4 of elderly patients with hip fracture show histologic evidence of osteomalacia, and 1/3 of these patients are vitamin D deficient, as determined by laboratory studies. The trend of covering the body persists even among Asian women in Western countries. They frequently remain indoors or wear traditional clothing, which limits sun exposure. A culturally related dietary practice, which may worsen osteomalacia among Indian and Pakistani women, is their consumption of large quantities of shuputi flour. This wheat flour contains phytates, which bind calcium and inhibit calcium absorption. I repeat, it binds calcium and inhibits calcium absorption. Lignin, also a component of the wheat fiber, binds to bile acids and further inhibits calcium absorption. Young adults living in northern latitudes and who spend much of the day indoors also develop osteomalacia, and dark-skinned women of all ages at the end of the winter have low levels of vitamin D. Although nutritional and cultural practices can lead to osteomalacia, the most common cause of this disease in the United States is intestinal malabsorption. Because vitamin D is a fat-soluble vitamin, gastrointestinal surgical procedures, as I mentioned previously, such as gastric bypass surgery or Bilros 2 partial gastrectomy, often lead to osteomalacia. In addition to surgical procedures, primary diseases of the small intestine, such as celiac disease, Crohn's disease, scleroderma, also result in poor vitamin D absorption. Hepatobiliary diseases also reduces vitamin D absorption. Biliary obstruction not only interferes with diminished bile release, but also impairs the hepatic synthesis of 25-hydroxy-vitamin D. Some patients receiving anticonvulsant therapy, particularly phenobarbital and dilantin, develop osteomalacia or rickets, which I have repeatedly mentioned. Approximately 25% of children. في حدا عم بيشطب على السلايد يا أخي. في حدا عم بيشطب على السلايدز. I would appreciate it if these are removed. Is this person يلي عم بيشطب على السلايد, does he have any question? Is there any argument in his mind لحتى عم بيشطب على السلايدز؟ شو يا خالد؟ خالد
دكتور جون
في حدا يمكن عم بيشطب على السلايدز. بدي
الان
إذا
ايوه الدكتور صلاح بيشوف يعني من اللي حرك ماوس او عم يشطب، لكن شالهم قال صح؟
ايه بدي اعرف عنده شيء اوبجكشن او بده اياني افسر له شيء بعد.
يمكن بالغلط يا دكتور جون، ما اعتقد، لا
طيب
ما اعتقد، لان نشوف المشاركين كثير حوالي 30
نحن
واحد.
هون مشان نعلي، نحن هون مش
اكيد
بس نحن هون
لا اكيد
مشان نجاوب
يمكن واحد
اسئله. اوكي
معنا 30 واحد مشترك يمكن بالغلط او كذا، بس ومعنا اكثرهم من خارج اليمن. ايوه
طيب ليك خالد كلهم عم بيفهموا كل شيء شو عم بعطي،
كل شيء واضح ويعني مبسطين ومستمتعين جدا بالماده يعني.
يضربوا حساب انه بعد في شيء ساعه بعد. يلا
ايوه عادي لو اكثر مش مشكله، اهم شيء راحتك انت يا دكتور ولا يهمك.
طيب approximately 25% of children on long-term dilantin therapy for epilepsy develop skeletal features of rickets. However, the incidence of abnormal laboratory values is higher. Patients usually have mildly reduced serum calcium levels and mild reductions in 25-hydroxy-vitamin D. Although poor nutrition, seen occasionally in epileptic patients, may contribute to calcium imbalance, anticonvulsants have been shown in experimental animals to cause mineralization abnormalities, even with controlled vitamin intake. فإذا سألت سؤال, which two substances will reduce calcium deposition and calcium and phosphorus loss, which would increase, would be hydantoin and phenobarb. Okay, so don't forget this. The anticonvulsant effect on mineral metabolism is really not fully understood. Apparently, these medicines result in a reduced sensitivity to vitamin D. In animals, phentoin inhibits the intestinal absorption of calcium, and both phentoin and phenobarb inhibit the mobilization of calcium from bone in vitro. Mild hepatic injury caused by these drugs decreases the release of 25-hydroxy-vitamin D. Treatment with vitamin D reduces the incidence of osteopenia and fractures in these patients. Clinical and radiographic features of osteomalacia. On rare occasions, osteomalacia is asymptomatic. However, 94% of patients have at least one symptom. Usually they complain of vague muscle aches, particularly in the back and legs, muscle weakness, and atrophy may also be present. Bone pain and tenderness may occur even when there are no obvious stress fractures. Bone pain can be severe and is the result of subperiosteal edema. The biochemical abnormalities associated with osteomalacia are highly characteristic. Patients have an elevated serum parathyroid hormone level due to secondary hyperparathyroidism and a low or normal serum calcium. The normal serum calcium level distinguishes osteomalacia from primary hyperparathyroidism. Patients with osteomalacia have low levels of serum 25-hydroxy vitamin D. Although the laboratory features are characteristic, some patients with osteomalacia lack the diagnostic laboratory profile. Therefore, evaluation of a patient by laboratory studies alone may be inaccurate. Only 47% of patients have low serum calcium, and only 29% have low serum 25-hydroxy vitamin D. Elevated serum parathyroid hormone levels are present in only 41%. A consistent finding, however, is an elevated serum alkaline phosphatase present in 94% of the cases. This laboratory finding, however, is non-specific and could indicate any high turnover bone disease. Radiographically, the most characteristic feature of osteomalacia is osteopenia, although changes may be indistinguishable from those of involutional osteoporosis. The presence of stress fractures or Lusa zones favors a diagnosis of osteomalacia. However, these zones are present in only 18% of patients. Lusa zones, transverse bands of multiple radiodensity and radiolucency occur most commonly in the femur and tibia. With the more highly sensitive bone scan, occult stress fractures appear as discrete lines of increased technetium uptake. This shows you a Lusa zone. Lusa zones are typically bilateral and symmetric, especially in the pelvis. Florid symmetric Lusa zones is known as the milkman syndrome, after the radiologist who described these features in 1934. If severe secondary hyperparathyroidism is engrafted on osteomalacia, subperiosteal resorptive changes are also present. This is a plain radiograph of the pelvis in a woman with osteomalacia. Multiple insufficiency fractures are present in the pubis and one in the ischial or inferior pubis. Pathologic fractures of osteomalacia. Because the laboratory studies are variable and the radiographic features often nonspecific, the unequivocal diagnosis of osteomalacia can be made only with undecalcified bone biopsy as I mentioned at the very beginning of this lecture. The accumulation of unmineralized osteoid is the most important pathologic feature of osteomalacia. You can see the purple is the osteoid. Here's the osteoid. This is the trabeculae. Okay? Uncalcified osteoid. So this photomicrograph of undecalcified section of the osteomalacia, there are wide osteoid seams. The osteoid seams are red, which means over here it appears purple, and mineralized bone is green. Using histomorphometric techniques, several characteristic features are usually present. First, total osteoid thickness is increased. Also, because mineralization is diminished, the amount of tetracycline labeling is reduced. Typically, tetracycline labels in osteomalacia are broad and ill-defined, unlike the typical crisp labels seen in normal mineralization. The dynamic indices of bone metabolism are also abnormal in osteomalacia. There is low mineralization rate and a low bone formation rate. Most characteristics, the mineralization, lag time, and index of efficiency of mineralization is elevated, often so many times the normal value. Treatment of osteomalacia and rickets. Rickets and osteomalacia can be cured with vitamin D therapy. Nutritional osteomalacia and rickets respond to oral vitamin D, usually 1,500 to 5,000 units daily. Also, exposure to an ultraviolet lamp or increased sun exposure may be effective. Effective sun exposure, 5 to 10 minutes a day on exposed arms and legs or hands, arms and face 2 or 3 times per week. For malabsorption related osteomalacia, treatment with 125 dihydroxy vitamin D3 20 to 30 micrograms per day may be more efficacious, although some patients are referred to tanning saloons. In addition to vitamin D therapy, calcium supplementation may be necessary, although care must be taken to avoid hypercalcemia. Oncogenetic osteomalacia, I'll go very briefly about it. The syndrome is known as oncogenic osteomalacia, which is a neoplasm that sensitizes abundant amounts of fibroblast growth factor, which acts on the kidney in 2 ways. The substance diminishes the tubular reabsorption of phosphate and leads to phosphate wasting. This effect mimics the pathophysiology of hypophosphatemic rickets. The substance also diminishes the renal activity of 1-alpha hydroxylase, resulting in a decrease in the synthesis of 1,25 dihydroxy vitamin D3. Oncogenic osteomalacia can be caused by a wide variety of neoplasms, although they are usually primary soft tissue bone tumors. Most commonly, the causative neoplasm is benign or low-grade malignant vascular or fibrous tissue tumor. The majority of these neoplasms have a distinctive histologic pattern with mangioparasitoma vascular pattern, a myxoid extracellular matrix and varying amounts of dystrophic calcification. This is a low-power photomicrograph of a phosphaturic mesenchymal tumor. There are numerous vascular spaces. Cells of this neoplasm, known as phosphaturic mesenchymal tumor, mixed connective tissue variant, are positive with stains of FGF23. Polyostotic fibrous dysplasia, neurofibromatosis, and metastatic prostate carcinoma may produce this syndrome. Patients with oncogenic osteomalacia present with unexplained muscular aches and hypophosphatemia. Bone pain and skeletal demineralization may also be present. Stress fractures are sometimes present. Plain radiograph of a patient with oncogenic osteomalacia. There are bilateral femoral insufficiency fractures. The diagnosis is suggested by low serum phosphorus with a normal serum calcium. It is confirmed by elevated serum levels, FGF23. In addition, serum 125 dihydroxy vitamin D is always low in these patients, and serum calcium may also be low. By contrast, serum 25 hydroxyvitamin D and serum PTH levels are normal. In the absence of renal disease, this constellation of abnormalities is almost diagnostic of oncogenic osteomalacia, even if the patient has no obvious neoplasm. Thorough clinical and radiographic examination usually uncovers a tumor. Often it is found in unusual locations, such as the base of the skull and sinonasal structures. Occasionally, however, patients present with the clinical and laboratory features of oncogenic osteomalacia, but a neoplasm cannot be found with extensive clinical and radiographic studies. Sometimes it takes months to years to discover the causative neoplasm. Complete removal of the offending neoplasm completely reverses the osteomalacia. If successful, the osteomalacia resolves. However, incomplete removal of the neoplasm necessitates treatment with phosphate and 125 dihydroxy vitamin D to ameliorate the skeletal disease. Renal osteodystrophy. Because of the importance of kidneys in calcium phosphorus metabolism, renal disease adversely affects the skeleton. However, clinically, significant bone changes, known as renal osteodystrophy, usually are delayed until end-stage renal disease. Prior to the use of renal dialysis, renal osteodystrophy was rare. Patients died before severe skeletal changes appeared. Nowadays, however, renal dialysis or renal transplantation support the estimated 300,000 Americans with end-stage renal disease long enough for them to develop clinically significant bone disease. Renal osteodystrophy may therefore be considered an iatrogenic disorder. Although symptoms of renal osteodystrophy are delayed until end-stage renal failure, abnormalities in calcium and phosphorus metabolism appear early in the course of kidney disease. For example, elevated parathyroid hormone levels occur in patients only 20% reduction in renal function. Therefore, in order to prevent late development of severe bone disease, management of mineral abnormalities is a concern for the clinical nephrologist beginning early in the course of renal disease. Renal osteodystrophy is a combination of secondary hyperparathyroidism and, to a lesser extent, osteomalacia. Secondary hyperparathyroidism is the most important factor contributing to bone disease. The principal factor stimulating parathyroids in renal failure is the ever-present tendency for serum calcium to fall. As a result, the constantly elevated serum parathyroid hormone level removes calcium from the bone. Although secondary hyperparathyroidism causes the bone changes, the principal driving factor in renal osteodystrophy, the factor that causes the serum calcium to fall, is hyperphosphatemia. Hyperphosphatemia is a result of reduced glomerular filtration rate and a failure of damaged tubules to excrete phosphorus. Also, the renal disease continues. Hyperphosphatemia is enhanced by the failure of the tubule to respond to phosphaturic effect of parathyroid hormone. Hyperphosphatemia can lower serum calcium directly. In addition, hyperphosphatemia impairs renal 1-alpha hydroxylase, thereby diminishing the synthesis of 1,25-dihydroxyvitamin D. As a result, calcium absorption in the gut is dramatically reduced, further increasing the tendency of serum calcium to fall. Thus, the inefficient entry of calcium into the homeostatic system due to vitamin D deficiency is responsible for the osteomalacia component of renal osteodystrophy. Now, a bit about the clinical features. Although abnormalities of mineral metabolism appear early in renal insufficiency, the symptoms of renal osteodystrophy are usually delayed until advanced renal failure, and this is bone pain is the most common symptom. Usually the bone pain is vague and localized to the back of the legs. However, sometimes the pain may be severe enough to require bed rest. The severe pain is usually due to pathologic fractures, particularly in the ribs and vertebrae. Patients with renal osteodystrophy also develop multiple stress fractures in weight-bearing bones, further enhancing generalized bone pain. Additional clinical features are muscle weakness, as we've repeatedly mentioned, myopathy, itching due to deposition of calcium in the skin. In children with renal osteodystrophy, growth retardation is common, a problem usually due to combination of malnutrition, acidosis, and osteomalacia. Because of the growth retardation, renal osteodystrophy in children has been called renal rickets. This is a patient, a plain radiograph of a patient with renal osteodystrophy. There is extensive subperiosteal resorption of the proximal humerus, and there is also extensive osteopenia. This is the rugged Jersey spine. Osteosclerosis present in 20% of patients is a striking feature of renal osteodystrophy. This change, due to extensive woven bone deposition, is paradoxical because osteopenia and cortical thinning are present in other parts of the skeleton. This is the rugged Jersey spine, where you have osteosclerosis secondary to massive deposition of woven bone at the end plates. This is a patient with osteomalacia. You see that you can see the vertical trabeculae, the horizontal trabeculae are gone. Okay. Brown tumors, we spoke about them. They also occur in renal osteodystrophy. This is a brown tumor shown by the arrow. They have the same histopathologic entity as giant cell reparative granulomas. So don't confuse it, as I spoke. So I don't want, you have to go into these, you have to study them on your own, you have to look and review hyperosteoidosis. You have to, because we cannot finish this lecture today. I just want to arrive to mention something. You have to look into these. I'm going to ask Dr. Khalid to give you these. Well, I would stay until tomorrow morning doing this lecture. Aluminum bone disease. You have to know why do they have it and why do they get bone. This was during dialysis in the past. Why did they get it? You have to look into it. This lecture will explain why. Okay, so please remember this. Amyloidosis and chronic renal failure. You have to know about it. Osteoporosis. This is our major topic for one of the lectures in the future. And why do patients get osteoporosis? And how does it occur in women? What about these patients who have anorexia nervosa? They have amenorrhea and they have considerable amount of osteoporosis. So you have to realize that following menopause, in several years, you begin to lose bone. You can use so much bone, as I mentioned at the beginning of the lecture, that would lead to osteoporosis. In men, usually at the age of 70, they begin to lose more bone. And you have to compare senile with post-menopausal osteoporosis. So don't forget about this. So please remember, we spoke about the peak bone mass at the beginning, and this has an effect on osteoporosis. You have to look at this. I think we have a lecture fully on osteoporosis. I won't go into it, but you have to know the basics. Now, you have to know why they get compression fractures, which is stronger. Is it the cortical or is it the trabecular bone? You have to look into these. Don't forget about the pathogenesis. I mentioned that you lose normally 0.3 to 0.5% of bone per year. Okay, so you have to know these. This is a very long lecture, which I plan to give you it in one lecture in the future. So this is it. Now, lastly, I would like to mention something about Paget's disease. I want to arrive at it. This is in the other lecture that we will be giving on osteoporosis. That's why I'm not discussing it. Or else we'll stay until tomorrow morning. We'll stay until tomorrow morning. But I would like to mention, I spoke to you about anorexia nervosa. These are the athletes who want to remain thin. They eat less, they remain thin, and they become amenorrheic, and as a result, they develop osteoporosis. Diabetes, you have to know about it. Smoking and alcohol, what's the effect on osteoblasts? All these are to be discussed in one lecture in the future. So I won't be discussed. Also, there's juvenile osteoporosis. You have to know these. Okay, so please read these, because if you don't read them, you won't know them. Even by listening to my lecture, you won't know them if you don't review them. Because this is a pure memorizing lecture. You have to know about transient osteoporosis that occurs following delivery. Transient osteoporosis. So these are points you have to know about. And I'm nearly approaching. And you have to know about reflex sympathetic dystrophy. I'm sure many of you, throughout your training, saw a patient who had a fractured wrist, was fine once the fracture, then in a few weeks he develops a severe pain in the hand with swelling, pain, localized tenderness, and osteoporosis, but due to him having a reflex sympathetic dystrophy. So you have to realize and how to treat them. Also, the shoulder hand syndrome and patients who have myocardic infarction. So please, this is another separate lecture. And Paget's disease also belongs to the metabolic bone diseases. And you have to know that there are 3 phases. 1, the lytic phase. 2, the blastic phase. Then you have the quiescent phase. And it can be monostotic or polyostotic deformities of bone. And they have stress fractures, but at the sites of the convexity of the bone, not on the concave side as it occurs in osteomalacia. And we know that it's related to paramyxovirus in osteoclasts, and maybe this is one of the main causes of Paget's disease, and it's present mainly in Northern Europe. It's rare in the Asian areas. So you have to know these, but there will be a next lecture on this. I'm just introducing it in metabolic bone diseases. Okay, thank you. Thank you very much. Are there any questions?
شكرا دكتور جون. المحاضرة يعني بناخذها وهم يقروها يعني صح؟ يعني
ما فهمت
يعني احنا المحاضرة اوكي. The lecture you pass in the final and you pass quickly. We
will be giving it at other times. Maslan, there will be a lecture on osteoporosis.
Osteoporosis, Paget disease.
You see, I passed very quickly on these because ولا رح نقعد لبكره
لا خلاص
فهمت شو؟ وانا بعتقد دكتور خالد تعب.
لا
دكتور خالد تعب. وشغله ثانيه انا بدي اقول لك next week I have a lecture to give at the American University of Beirut, and it's on periprosthetic infections.
Correct.
بقى رح
Infection.
بعطيكم انتوا next week رح بغيرها بوقت يلي عم نعطيكم periprosthetic infections رح بعطيكم اياها next week. Okay? So as to
Okay,
be,
then it's Friday.
it will be next Friday. Okay?
Okay.
Okay.
Okay, thank you, Prof.
Periprosthetic infections. A good
Okay.
part, I'll tell the boys, they should look up Parisi. Parisi has written books and various lectures on this topic. Okay, it will make it easy for them to remember. Okay, thank you very much, and
Thank
thanks
you.
to everybody.
Thank
Yeah,
you, sir,
bye-bye.
and I will contact you about the
أنا رح
candidates.
بشوفك بالأردن وإذا في
Okay,
شيء
حاضر.
حكينا
Yeah, I will contact you.
اوكي وكل شيء
Thank you
بقول
very
لك ماشي كل شيء ترين ماشي
إن شاء الله.
ما بين اليمني بس they should realize that even if they pass it's a conditional passage unless they
Yeah.
finish their train. Okay?
Yeah. Okay. Thank you very much.
Bye-bye.
Bye. Oh my God.